of the National HPV Vaccination Roundtable, welcome to the second We're in 2020 webinar. I'm Jennifer Konga, Director of Health Systems and Provider Engagement on the HPV Roundtable. We're in 2020 is a national initiative to catalyze U.S. health systems to prioritize HPV vaccination for cancer prevention. To achieve the Healthy People goal of 80%, it will take concerted effort through healthcare systems if we are to reach population-level protection. We first want to issue a very warm welcome to the over 24 health systems and public health organizations that have already signed on in the first month of We're in 2020. From the coast of California and Oregon, across the country to New York, north to South Dakota, Minnesota, down into the Oklahoma plains, and deep into the heart of Texas, we are very excited to grow the family of organizations prioritizing HPV cancer prevention. You can find this full list on our We're in 2020 webpage, which is listed here on the screen. For the organizations that have signed on, please know that we are in the process of reaching out to you and sending you your certificates, so please stay tuned. We'll be with you in the next week. Later in this call, we'll review how other organizations can join on to this nationwide call for action. On today's call, we'll be hearing from two experts on using data and selecting interventions to improve HPV vaccination rates in practice. This month's webinar showcases Park Nicollet Health System in Minnesota, a member of the Health Partners family. Throughout the call, we'll do our best to address your questions. If you hover over the bottom of your screen, you'll see a Q&A pod on your menu bar where you can post questions for speakers. Time permitting, we'll answer those questions in the pod box or at the end of the call. If you were on last month's call, you'll know that we still have yet to get those frequently asked questions posted. So we'll be working on that as well, and we'll post them to the We're In webpage. This call is also being recorded and will be posted to our YouTube channel, where you can also find a recording of January's launch call in case you missed it. So with that, let's get to introducing our first speaker. Marcy Fisherborn is the Senior Director of HPV Vaccination for the American Cancer Society, where she leads the HPV Vaccinate Adolescents Against Cancers program, also fondly known as VAX. VAX is partially funded through the CDC, and it's a national initiative to improve HPV vaccine rates through evidence-based quality improvement interventions in health systems and through other key clinical, state, and national partnerships. To date, the VAX program has supported year-long quality improvement projects in over 1,000 clinics in the United States. So with that, let's welcome Dr. Marcy Fisherborn.
Hi, everybody. Jen, will you give me a thumbs up that you hear me? Or a verbal?
I hear you.
Great. Good afternoon, or early morning afternoon for those of you on the West Coast. I'm really glad to be here to talk a little bit about what we have learned over the last few years through our American Cancer Society Quality Improvement Interventions, partnering with you, health systems, and other key state and national partners to drive HPV vaccine uptake around the country. We're going to be talking about data, and we're going to be talking about strategies to use once we get that data to improve rates. But before that, I want to say a little bit about why I love this work and what my anchors are in this work to really help ground the conversation this afternoon with you. The first is something that I remind myself on a regular basis as we tackle some challenging problems, when it feels like we're tackling challenging problems, is that we actually, with HPV vaccination, have a solvable problem. We have a vaccine that can prevent up to 6 types of cancer. We have an adolescent platform where other vaccines are being taken. So the group of all of us on this call today and many others are problem solvers, and we've done incredible work so far. We have some room to go, and we're really excited to do that work with you. So again, I say to myself, this is a solvable problem. There are lots of parts. We're going to talk about some of those parts as they involve data and evidence-based interventions, but it's solvable. The second thing, skip more than one. It looks like it's missing. I had a picture here that for some reason is not showing up on my screen, and it's a picture of my daughter. So I'm sorry that you can't see that, but this summer my 11-year-old was vaccinated. And one of the things I've tried to be more active in saying when I'm speaking in public, when I'm talking to my neighbor, is that I am a pro-vaccine parent. And that's an incredible, important anchor for my work. We are living in a time that is incredibly complex around vaccine hesitancy, where while it's a very small minority population, we have a strong anti-vaccine voice in this country. So talking about how we are and continue to be pro-vaccine parents, friends, grandparents is incredibly important and is another strong anchor and story in terms of why I do this work, and I'm incredibly motivated around this work. In terms of an anchor for the American Cancer Society and how we do this work, the conversation that I'm going to have with you during this hour is framed in our Steps for Increasing HPV Vaccine in Practice framework. So there's a link here, and later in this presentation, Jennifer Conga is going to talk about some of the resources. Our STEPS guide is a 4-step process for working with providers and their staff in a system to increase vaccine rates. This is the second we're in call, so starting to think through who is our team is a conversation that we hope you've begun. It will be part of the conversation we'll have today around data. And we're really going to focus on that second step around making a plan. What I love about this tool, if you haven't seen this tool, is that within every step is a link to very specific curated resources that are not just from the American Cancer Society, they're from the CDC, AAP, and many other partners that help move through each step of the process. So we're going to talk a little bit about your data team today. We're going to talk about making a plan. The other thing that's incredibly important as we frame this work is that there is a season to our work. So when we look at time and we look at when children are most likely to get the vaccine, May through September is a really important window. So I'm saying this as a frame because as we talk about what interventions we may select, knowing that the sort of peak time for engagement with parents is a very short window, right? We don't have the entire year. So if we're going to make systems changes and improvements, as some of the recommendations will be, some of you may already be doing, now is a really important time to be doing that, doing it before we hit that peak vaccine season in May. All right, so we're going to talk a little bit about data, and we know that what gets measured gets done. So let's think about what that can look like at a system-wide level a little bit. The first conversation that we want to have is really thinking about who the players are that are going to be part of the work. Data is a team sport. So when you're exploring HPV data, when you're interpreting it, when you're deciding what you're going to do with it, it shouldn't be done solo. It really should be done as a team. So who are some of those folks? And feel free, earlier, Jen Conga said, use the chat if you're like, oh, this is a really important player for us. Please put that name, that group of people in the chat so we can add that to the conversation. So they can be your informatics team, your EHR team. Clinical champions are incredibly important. We're going to talk about that in a little while when we talk about evidence-based intervention. Your clinical care team, your clinical quality coordinators, all of your quality improvement team, at least your quality improvement lead, family med, pediatrics, population health staff, cancer center, who else, right? So this is a long laundry list. This isn't all people at all times at various phases. You're first trying to figure out where are our data, where do we even start? It may be a longer list. It may look different at different times depending on where you are as a project, but really starting with, okay, who are those key players that are going to help us understand where our baseline is going to be really important. All right, I'm going to go back. Sorry, my slides are advancing a little quickly. One more. So those are the players. I'm going to talk a little bit about roles, and there can be a variety of roles. So we can have folks that are going to actually be providing the tools that we need to explore our population, how we're going to measure it, report checker, the folks that are going to create our dashboards, person that's going to connect us to the resources that we need to be able to pull the data. I mentioned earlier a clinical champion. They may do all those roles. They may serve as a cheerleader. We may have someone else that serves as a cheerleader. Maybe there's a nurse coordinator who knows exactly where we need to go, as an immunization champion for another issue. We're just taking on HPV vaccine work. Okay, great, we're going to cheerlead that. Question answer, hopefully we have a group that can be part of that work, and asking good questions. Some of the data work is really being able to look at the data and ask important questions all along the way. So with that, I think we have a poll. Oops. All right, so Jen, I'm going to need you to ask that question for us. And I think the question is, the poll is going to come up in just a second. When you think about the role you feel the least comfortable with, it should be at least familiar with, sorry. It should be up on your screen now as another pop-up poll box. What is the data support role you feel the least familiar with? We'll take 2 seconds to let everyone answer that question. While that's happening, I just want to note, I'm looking at the chat. We have other, in terms of other key players, our immunization coalitions, our registries. Absolutely, these are really important. And I would just take the moment to say, because I know we have folks on the call that are partners to health systems, that help work with the immunization registries, that help support quality improvement and HPV vaccine efforts in your state, in your area. These partnerships are incredibly important. Okay, and Jinkanga saying, vote people, but some folks are unable to see the poll box. I think we are getting some votes. So graph creator. We're going to talk a little bit in a second about, show a visual at least around what some of the dashboards can look like. So this can be your IT team. Some folks for specific EHRs have separate ITs and EHR teams. You may have a physician champion that works on dashboards. Your quality improvement team may be that team. So who are the folks that can help create the graphs, the dashboards that are going to help your team know where they are, where they're going, and visualize where they want to be? It's going to be really important. Thank all of you for answering that question. All right. Nikki, there we go. All right. So we've talked about some of the players. We talked a little bit about the roles. Also important, and I would say in tandem, as these folks are coming together, we are asking, what are the problems that we are trying to solve? What are they? Are the problems multi-level? Are they state, system, clinic, provider? Are we trying to understand trends over time? What did it look like last year? What did it look like in 18? Where were we in 19? What was it in this quarter? What was it in all the previous quarters? Are we trying to understand where we are with initiation? Are we trying to understand where we are with completion? Do we need to see both to understand a comprehensive story? What about missed opportunities? Missed opportunities could be HPV compared to the other adolescent vaccines, Tdap, meningococcal. Missed opportunities could be having sick visits, where perhaps vaccines could be offered but aren't, right? So what are our missed opportunities? Are we trying to solve for that? Or are there issues in terms of gender gap? Do we see differences in boys and girls? Do we see differences in boys and girls in initiation and completion? It's really important as you start to pull data that you ask these questions. Maybe you're not trying to answer all of them. You're trying to figure out what are the most meaningful questions to us. The other thing you want to figure out is, how are we going to use our data, right? Are we using the data to inform all the aspects of our work, our interventions, our workflow, our progress, the locations of clinics? So we want to have a gap care clinic. We've done it before for maybe childhood immunizations. Now we want to do it for adolescent vaccines. Okay, well, we see that we have some missed opportunities. Maybe if we had Saturday clinics or some extended hour clinics or some nurse only, clinic time, that these would be ways we could address our problem. So really identifying what are all the aspects of our work where we could utilize data. Obviously, provider assessment and feedback. One of the earlier questions in red when we just did that poll was, oh, the graphs. How could we use graphs? How could we use dashboards? Giving providers very clear assessment around where they are, where they may be compared to other providers within a clinic, or they may be as a clinic group compared to other clinics within a system. All of that's important. You may say, you know what, we really want to use the data to focus on very specific things. We're a large health system. We have many clinics. We want to focus in on 2 sites. Maybe they're the largest 2 pediatric sites. Maybe we really want to focus on initiation, because if we have to start somewhere, we know that's a great place to start. Maybe we want to use the data for competition. We see clinics that are doing relatively well with initiation. We have 2 or 3 that aren't. Or we really want to focus on completion, and we think if we had some competition between clinics that may be some sort of incentive. I will say, thinking about competition as an incentive for all staff, so we'll talk a second about provider incentives, but when you think about the change we need within a system, every staff person is vital. So how could competition be used to really motivate and incentivize an entire clinical system, a specific clinic? And then you could also use your data to celebrate successes or bright spots, even early in the process. So you're really trying to understand, well, where are we right now as we start this project? Or where are we right now in specific clinics? And you find out there are just some shining stars in terms of providers. Their rates are incredible. How could you use those to cultivate future champions? There's a lot that can be learned around successes when you start to look at your data as well. All right, the next thing, when we think about data and we think about how we can use it to really inform our planning, is understanding the population. Right, just as we have to know who's on our team, how we could use our data, we need to know who are we looking at, right? Who's an active patient population? What's your age? How are we defining on-time vaccination? Are we talking about 9 to 12? Are we talking about 13? Are we talking about a specific time period? Do we want to just look at the last 12 months? Do we want to look at the last 24 months? So because we know some parents don't come back for a well child visit right at month 12. Maybe they come in at month 13. So we want to look over a 24-month window. So defining that is going to be really important. So active patient population, maybe those that had 1 medical visit in the last 24 months, maybe 12 months. These conversations are really between that team. That's why that earlier remark, data is not a solo sport, it's a team sport. So really thinking, what's the most meaningful for our particular environment? If you're not using the same age range, the same time frame, what you might find over time is an apples to oranges comparison. You don't want that to happen. So making sure that you set those priorities, that you identify who is the population, what is our time frame early on, and that based on that, you're capturing data consistently. All right, so big picture data questions, just to keep in mind. Every data pool should have a purpose, right? It should be something that you feel like, okay, we know exactly why we're doing this. We know how we're going to use it. If anyone asks us, we can answer that question. And it goes hand in hand with those earlier conversations. So it seems relatively intuitive that data should have a purpose, but it doesn't always end up that way. And sometimes we end up pulling complex, confusing data, bringing team members in at the wrong time with that confusing data, and not really knowing exactly why we did it, what we're doing. So I want to say a little bit around requesting data, because many of us on the phone, so whether you are on this call and you are a health system staff, or whether you are supporting player and coach, whether that's an ACS staff person, immunization manager, many of us are not the folks that are directly pulling the data. So when you are requesting data, here's some things to keep in mind. How can you ask for data in ways that you're going to make sure you get what you need? So this conversation is the reality check conversation. And some of you on this call may say, we know this already, but you're going to really want to start early, because chances are you're going to have to do some revision. You're going to have to go back and look at how you define your measurement. Okay, so what do we say the active patient population is? Do we really want to group 9 to 13? Do we want to separate them out by age? You know, really sort of making sure that you define that in a way that's going to make sense for the project long term and that you're going to do it consistently. Having those conversations and having the reality check that you may do that data pull, look at the data and say, we have some questions around this. We're not quite sure this is right. Or we look at the data and we realize, oh, we just pulled well child visits. Maybe we do need to pull sick. Maybe we have sports physical visits that we could pull. Maybe there's some sort of sick follow-up visit. A number of clinics have things that can be coded as sick follow-up. Maybe we really want to pull those because that may be a time where we have actually vaccinated. So thinking through how are we going to request the data, starting that process early, knowing that you may have to look at it a little bit. In terms of tools to help you, on the HPV Roundtable website, you will, and inside the steps guide, you will find a data tracker tool that has really wonderful visuals of how to pull data by age range, by provider, by clinic, by system, and we'll shoot out some really nice graphs. So that early question, I don't know, how do I get those graphs? If you don't have someone on your team that could do that and you want to take out the data tracking tool, wonderful resource. Also some PDSA templates that can help you around that as well that you'll find in the steps guide or also on the HPV Roundtable website. So there's this process of tidying your data. Think Marie Kondo. How do we take this in bits? Maybe we start with the shirts and the clothes in the closet. I think that's a recommendation. And we see what we get. This again, reality check, this may take time. So other data realities, just want to run through some of them, make sure we're all on the same page. Quality improvement is data driven. While I would make the argument that just this process of saying, okay, we've gone through the data, we've looked at it again, maybe we've gone back, we've had to pull again, but we know what it is in a way that we can tell providers where they are in their staff. Here's where you are as a clinic. It's going to incredibly increase the likelihood of success. So quality improvement is data driven. We can't start talking about what we do till we know where we are. Most of us on this call and that will be driving this work are not going to be HR record experts. We may need them along the way, but that's not what we'll be doing. So most of us do not query or look at patient level data all the time, right? So how do we really think through this may take multiple brains. Data isn't static. It's meant to be questioned. It's meant to be tweaked. Having those right people at the table to ask those good questions is going to be incredibly important. And it could tell us a lot of different stories. So if you're looking at data and thinking, okay, well, should we be transparent with this data? Do we have unblinded data for providers? Some of those are really going to be culture questions for you as a system, but really thinking through from the start, how could we use the story to tell some positive change that we maybe already have made, even if that's one or two sort of rising champions. How do we understand our data right now to tell stories? They don't have to be negative stories. They could be really great stories about what work has been done to date. The data may be imperfect and have limitations. You may look at multiple data sources in EHR, your population management system. You may be pulling chart audits to help understand whether your data is accurate. Of course, through your immunization registries that you would be looking at as well that could provide some picture of where you are today. And you're going to be asked to interpret live data. And I'll say, because I know we have some American Cancer Society staff on this call who often serve as quality improvement coaches and partners in helping HPV vaccine projects, that many of our sort of support players that are on this call may be asked, okay, well, what do you think? What should we do? Do we start with initiation? How much should we care about our rate differences between boys or girls? And that's okay to think through that and to help serve as a support person along that role, because for you health systems, you aren't alone. And there are many partners that are on this call and in your community that want to help this work be successful. All right, so we talked a little bit about the sort of main buckets of thinking through data quality, of being able to ask as a team, is our data complete? We're going to talk a little bit about data interpretation before we talk about how we take that data interpretation and figure out what to do. So when we talk about interpreting data, we are asking questions and we are saying, all right, what do the data we see, what does it mean? How can it shape our project goals? How does it shape the interventions that we choose to do? We're asking questions around what we see in the data. What does it tell us about where we are with initiation and completion? How do we see where we are in connection with other adolescent vaccines? Do we think that's accurate? I mentioned this earlier, but certainly if we see differences in gender and differences in age groups. So 11 to 12 is on time. Some systems are starting early as 9. Is that something that we want to consider? What might that mean around the conversations providers would or wouldn't have? What does it mean to possibly be able to catch more preteens in a visit if we started early? These are all conversations that can happen. It can happen when you look at your data. So long story short is that before we say, okay, let's do the work, what should we do? How do we make an impact? We're going to answer some of those questions first. We have to answer those questions first by looking at the data. We're looking at our clinic data, our provider data, our system data. If we're working at a state level, we're looking at our registry data. Some folks are looking at ordering data and trends in ordering data on an area or on a state level. So before the whole team gets excited and makes a plan, make sure that plan is grounded in the data. All right, so with that, we're going to talk a little bit about the what we do next, and this is a poll opportunity. So hopefully you will see one pop up which says, when you talk about the evidence-based interventions, what are the ones you are least familiar with? And there are 8 that should pop up on your screen. So we'll take 2 seconds and let you check 1 or 2 or 3, it's multiple choice. Which evidence-based interventions are you least familiar with? All right, and I don't see answers yet, but I'm hoping someone's going to close that poll and we will move on to see what folks say. Okay, so I'm seeing the poll results. I hope you are as well. When I look through the list, it looks like reducing structural barriers. Although I will say 1 out of 4 are almost good with all of these, so that's great. If that's you, please pass it along to your neighbor and share what you know. Okay. First thing I want to say, and I'm going to unfortunately have to run relatively quickly through this so we stay on time, but the most important thing for you to hear around the conversation with evidence-based interventions is that the most impactful ones involve multiple levels. So we're thinking about the patient and the parent, we're thinking about provider and staff, and we're thinking about what are the structural barriers, what are the structural opportunities to increase access. And I want to make sure that we have some time for that, given that there was definitely interest in that. Other important thing I want to say, let's get back a second, as I mentioned the steps guide, I'm going to mention it again and say that one of the things we really focus on in the steps is that you start with 1 or 2 strategies. So you're looking at your data, you're thinking, what can we do? And you're not taking on the entire pizza pie. You're choosing 1 or 2 slices and saying, here's where we're going to start. I'm not going to spend a lot of time on professional education, but I'm going to remind everyone that we know that the provider recommendation is one of the most significant factors in a parent choosing to vaccinate their child. So making sure that conversations around provider education are happening, that we're asking, what does it mean to be a pro-vaccine culture? What are we doing to make that alive? What new training might we need? And how are we making sure that the whole entire office staff are part of that, right? We can have a great provider recommendation, but if there is a moment from front desk till that moment with a provider where a parent has been presented with information or a question that makes them question the vaccine, then we really have done a disservice. So thinking through how we get all of the office and clinical staff on one page. The Roundtable has a great All Systems Action Guide that I just would love to flag for you as a wonderful resource in that process. So, provider education resources, I'm going to skip through that. They're there for you. Jen Conga is going to talk to you about it more. Provider assessment and feedback. How do we use dashboards to create more transparency in a clinical setting? So the example you see here in red, I might come in, this could be a best practice alert that tells me where I am in connection with other providers in my clinic, other providers in my system, in terms of my patient panel being up to date with vaccines. I might be doing a great job, so I'm a bright spot. That's so good to know. I can become a champion in the process. So I said earlier, these can be used for dashboards, they can be used for competition, pay per performance, providing individual incentives to providers to increase rates is certainly a possibility. So we talked about this, knowing rates are going to improve process. Standing orders, so when we talk about structural barriers, if we only have providers able to provide vaccine, that's limiting. What does it mean to enable a policy that's going to allow other health professionals, the nurse, the MAs, both to be able to administer the vaccine? Also having standing orders, maybe we have nurses, MAs administering vaccine in extended hours, over weekend hours, through our urgent care. These are all ways to increase access, to make more opportunities available to parents to choose vaccination. And I'm going to skip through this just to make sure that we get through everything. When we talk about provider reminders and prompts, it's really important to know that the EHR pop-ups or best practice alerts aren't the only way. So having a note that says, hey, this is your patient, or this is your group of patients that are going to, that need vaccine today in your panel today, can be really effective. Having some sort of pre-note, having a discussion in a daily huddle. Okay, here's what's coming down the pipeline today. Here's what to be ready for. All of these can be incredibly impactful to letting that provider know that she or he has a patient that's going to be due for vaccine. I will say you'll have access to all these slides. So if you're like, oh, I want to know more questions I can ask specific to that, you will be able to have access to this. When we talk about patients, so when we talk about EBIs, thinking through, well, when's the best time to implement a patient reminder recall? That's probably going to be at completion, right? That may be intuitive, but just to remind us, that may be a better practice to institute when we're thinking about making sure that our patients are up to date and that the vaccine is complete. We may have our EHR portal, that will allow us to do all kinds of fancy things. We may be able to send text, emails. Phone calls are a more expensive way. Some systems do have clinical quality coordinators or other staff that can make those phone calls, thinking through if that's possible and whether the resources are there to do that. This is, in terms of impact and evidence around this particular strategy, it's small to medium in and of itself. One of the particular challenges with patient reminders, if you choose phone calls, for example, is that the resource cost to that can be quite high if you're using staff time. It is the most effective for second dose. We have a whole bunch of examples of questions you can ask around patient reminders, but I do want to say a few more strategies around access. If possible, if EHRs can be set, if there are other strategies you could put in place as a system to schedule that next dose before the patient leaves. Now, some systems are not able to schedule past 3 months out, so really thinking through, if this isn't possible, what are going to be our strategies to make sure the vaccine is complete? And then thinking through, how do we make sure this vaccine is administered at all of the opportunities we may have within the clinical system? Now, I'm a mom, I mentioned that earlier, so if I'm bringing my child in and she has the flu, that may not be the best time. But if I'm bringing my child in who had a rash and now it's a follow-up visit, did that rash go away? This may be a great time to tell me, oh, I'm not up to date. It's time for a vaccine, and to make that happen. Sports physicals, a number of systems still provide sports physicals. That could be a great opportunity. And thinking through care gap clinic days or extended hours, nurse-only visits, where are there opportunities to do that? And I would also just encourage you to think, if the HPV vaccine work is new, have there been other places and spaces and work, so for example, around diabetes, where you may have been able to create new opportunities to address patient needs? How have you been able to increase access for those particular areas of work? how might they still apply to this area of work when we think about adolescent vaccination? So if you have visits, maybe you've extended your hours, or you decided, oh, this is back to school, we're talking about some summer walk-in clinics, making sure that those are promoted, that parents know they're there. I mentioned already adding regular weekend or clinic hours or extended clinic hours, and thinking through back to school. So I started by mentioning that vaccine window. How do we make sure that during the time when parents are thinking more about vaccines, that we're getting them in for the HPV vaccine? All right, so I'm going to skip ahead here because I want to make sure that we have time. One last thing that I want to say is around maximizing your use of EHRs. So quality dashboards, providing provider tools, that was an example I provided earlier, putting up best practice alerts, appointment reminders, thinking through on a patient level, how are we using member portals for reminders, recall, overdue alerts, even education. Hey, we're having a back to school vaccine clinic, here's what you need to know. So in summary, ask who needs to be at the table. Make sure you have a team, and make sure that team is thinking through the population you are trying to impact the most. You're clear on the problem that you're trying to solve. We're really going to focus on initiation. Remember, 1 to 2 things to start with. And then you really know how you're going to use the data once you have it, and you're going to share it. Some of the best projects are those where you're having data transparency, thinking through, do we already have a culture of data transparency? If we don't, how could this opportunity be one that's transformative in that way? And then finally, how do you use your data to inform all of your interventions decisions? Don't start big, start small, so you can know that you're seeing and tracking success. I'm not going to review these tools. There are links to each of these. Jinkanga, I think you're going to go over more at the end of the session. And with that, I'm going to turn it back to you to introduce Dr. Singh. Thank you so much.
Thank you, Marcy. And I know there's been at least one question in the box for you, so I'm going to ask you to check that out while we get ready for Dr. Singh. Also, a reminder, if time permitting, we'll have some questions at the end. But now we're going to hear from Dr. Andrea Singh, who's the chairperson of the Department of Pediatrics at Park Nicollet, as well as co-chair of the Health Partners Children's Health Initiative. She's a practicing pediatrician and mom of 2 adolescent boys. In addition, Dr. Singh currently serves on the Medical Advisory Board for Virtuwell, which is Health Partners' online clinical care platform. She volunteers as a pediatric medical advisor for Make-A-Wish of Minnesota and serves on the Governor's Children's Cabinet Advisory Council. She was the 2019 Minnesota HPV Champion, and we're also delighted to announce that Park Nicollet has recently signed on to the We're In 2020 initiative. So with that, please welcome Dr. Singh.
Hi there. I'm honored to be part of the webinar today and partnering with the American Cancer Society to share with you guys really what we've been doing as a health system. And the Park Nicollet Health Partners Health System is a large multi-specialty healthcare organization. So we have a lot of opportunity, but we always have a lot of opportunity, but we also had a lot of gaps, quite honestly, with where we were going with our rates of vaccination and what we could do to move along. Okay, so let's figure out how to advance the slides. There you go. Maybe, Jen, you can help me with that.
Sure can.
Yeah, thanks. If you just want to go to the next one. As far as the vaccine rates at Park Nicollet, what we found was that we were really lagging behind. There we go. And I will start with why we actually, their vaccine rates for Park Nicollet, we were really lagging behind in terms of HPV vaccine rates. And so we chose to tackle HPV immunization rates in succession, really because we knew there was an opportunity, but we also knew, as Marcy really nicely put it, this is a solvable problem. It's costly, it has high mortality and morbidity, and we could do something about it. When you look at Park Nicollet or overall as an organization's rates for HPV vaccination, we got a first dose in about a third of the time. Completion of the series was only at about 20%, and we clearly lagged far behind the vaccines that we were supposed to be doing at the same time there, the meningitis and Tdap rates. We also were, maybe in the range of our fellow institutions here in the Twin Cities and Minneapolis, St. Paul, but we had a lot of work to do. So, I skipped over the reason why, the prevalence rates, because we've talked a lot about that. And I think we're on this call because we understand that HPV is a big deal. And so really what I want to spend my time sharing with you guys is what we've done as an organization, and we've done a lot. Marcy made a point of saying, start small and start with something that you actually can tackle as a group, as you've looked at your data and seen what was manageable. And I think that we did that, and then we have taken things a few steps further. So there's a lot on this slide, I know, but we're going to go piece by piece with it. And so that we can see where we partnered with the American Cancer Society, where we took some initiative and kind of did things on our own, and where we tried to look out of the box and where we're going to in the future. So looking at our HPV interventions, the first thing that we did was decide that we needed to partner with experts. So we were really lucky to partner with the American Cancer Society and adopt a maintenance of certification project. That solved multiple problems. Number one, we were educating our teams on how to talk about HPV vaccine and bring both our care providers as well as our support staff on board with some of this. We were able to utilize the fantastic resources that Marcy has outlined and that we've put in the chat for you guys to all tackle. But we had to start somewhere, and we also served the purpose of providing MOC benefit for our clinicians. So for those individuals that were not super keen on one more lunchtime meeting or one more webinar or anything, they were also getting the benefit of helping their board certification. And we did 4 quarterly meetings, all available on our quality team's website. So people could access them if they were not available during these meetings. We tend as an organization to do a lot of lunchtime meetings, so hopefully people can join these educational opportunities when they're not seeing patients, but we do archive them and make them available for everybody. And we utilized a lot of the stuff that the American Cancer Society had provided through the National HPV Vaccination Roundtable Clinician and Health System Guides that we've already talked about. We also have Immunization Champions in our organization that traditionally have looked at other childhood vaccines, and we made sure that we were giving regular updates to those individuals. And I'd like to call out, one of our younger physicians, Dr. Garrett Jones, who championed this work and championed the WebEx and some of the information, along with Allie Solito, one of our awesome quality improvement nurses who helped me with the slides today and also has been a huge champion in this process throughout. And the person responsible for this, really it was everybody involved in this MLC project, and we invited not just clinicians, but also whole staff and all the partners to listen to these WebExes. Now, this is an example of the Roundtable Guide, and I know we've seen this already in the WebEx, so I'm not going to spend a lot of time talking about this, but I just think that for those of you that are in large multi-specialty organizations or even in small healthcare organizations, really knowing that these are available and that these guides address roles that various clinical care staff can play to help support vaccination in their clinics, these really help all team members speak with one voice when we're talking about this vaccine. And, I wish that HPV vaccination was not controversial or that it was as easy to convince somebody of as Tdap or meningitis vaccines, but it's not. So we have to be very purposeful in what we're doing. And that's the take that our organization has moved forward with. So, in that Roundtable Guide and in our WebExes, we focused on a few things. And I'm going to cruise through this because I think we kind of talked about a lot of this already. But number one, we reminded clinicians that they needed to be an advocate. If you're not strongly recommending the vaccine, then parents are going to consider it optional a lot of the time. And so it's really important in the language that you use. And as I said previously, even though this slide is identified as clinician role, we made sure that everyone that is interacting with the patient was also using the same language and had the same understanding about why this vaccine was important. We wanted to make sure that we are using presumptive language. So in that WebEx, we talked about what's the difference between presumptive language and participatory language. And again, it's kind of making sure that parents recognize that this is part of a routine maintenance of health for your child. And this is not like an extra, like an add-on, like, oh yeah, let's get the cool spoiler on the car. This is, okay, let's get the steering wheel. And I think that that is really important for parents to hear, and also our care staff to hear. You know, don't offer to delay the vaccine, because if you give parents an out and they're looking for a way to maybe not look like the bad guy in front of their child who says, well, I need 2 shots, but maybe 3, and if you want a flu shot, it's 4. Well, if I can take one of those away, why not? And if the clinician or the care provider is not giving them the option to delay the vaccine, then that's actually very helpful. And, you know, all of this is based on data that we have gotten from the American Cancer Society, the AAP, Journal of Adolescent Health, various places. So we really use the evidence to support what we were presenting to our clinicians. And you can see the data there. Same-day HPV vaccinations occurred much more frequently when delay was not offered. And that's, I mean, 82% versus 6% is startling in this particular article. That's what they found. And then feel comfortable addressing questions and concerns. All of our care team has to know what the best resources to use are. There's a lot of scary stuff online, and parents just Google things. And we know that we don't control what comes first in the search engines. And so we need to be able to very comfortably tell parents what resources they should be looking at and what we've used to care for our own children and our own patients. All right, and then minimize missed opportunities. So review vaccines at every single visit. We have a little piece of paper that providers will take into the room with them where they write their notes and things, and on that, we've made sure to have immunizations, and when nurses or health staff are doing pre-visit planning, they're writing on there what vaccines are needed, whether the child is here for a rash, you know, a sprained ankle, or a well visit. And that's been very helpful for us to catch those opportunities that may not be so obvious. Even if families decline, plant the seed for, well, next time we are probably going to do this. So, you know, I would recommend doing it as soon as you can. And you can certainly use the sticky note feature in your electronic medical record. And I know Marcy talked about all the different ways that we can kind of remind each other, remind the care teams, and remind patients about this. But I think emphasizing that in our web series was really helpful for our teams. So the second thing we did in terms of HPV interventions last year was we made sure that we were addressing that provider assessment and feedback piece. So we gave people data, and we said, here are your vaccine rates, here's how many opportunities you had, here's how many missed opportunities you had. And we made sure at quality meetings that are being held monthly with our local care teams in our system that that was a conversation that was had. And so we could kind of identify where things were at and where people needed to go. I think that was really critical because it's moving HPV vaccine rates up into a level such as other traditional things like diabetes and things like that. So really, really important as far as that goes. We also tried really hard to leverage data. And so I know Marcy talked about a bunch of different dashboards and things that people have in their systems. We have a very transparent dashboard that is unblinded, actually. Today I've blinded clinician names and obviously patient names, but and giving you an example. But we have scorecards that our teams use, and each local team gets scorecards that drill down all the way to the clinician and even patient level. And so you can look and see how many of your patients met combo 1 for Tdap and meningitis, how many met combo 2 for one HPV, Tdap, meningitis. You can see how many of your patients got 1 HPV, how many of your patients got 2 HPVs and completed the series. This definitely drives healthy competition in our organization, and we do this for all of our quality measures. But having HPV specifically called out, having it available in a place where people can drill down has been really important. And a real success story. And then we actually color code these. So green means you're doing great and you're right on track. Yellow means you've got some opportunity, and red means you're below target, and we may be having to think about some interventions. And so that's what I have printed here. So you can see we've pulled out these are our individual clinic sites. We can divide it further into care teams if we want, so family medicine, med peds, pediatrics, and we keep going. And so that's been a really neat thing that other organizations could certainly think about utilizing. And then just wrapping up, things that we are continuing to think about and do in the future. And I think this is where you start to think out of the box, and how do you use that data and the opportunities that we have to partner with care teams. So, the question was posted in the chat previously about who else should we be thinking about. Well, we started thinking about, we have a large multi-specialty group. We have a lot of urgent cares. If we can leverage patients coming into urgent care and get them at least hooked up with primary care to get maybe a second dose of vaccine, I think that's a huge opportunity. We also have dental clinics. Our dentists have been super eager to talk about HPV vaccine and preventing oral cancers and throat cancers. And so both of these groups, so what we did was we said, let's not necessarily ask those clinicians to have the first conversation about HPV vaccine, but if a patient has had their first dose and they've already expressed a willingness to get this vaccine and they're just due for their second dose, can we create some sort of warm handoff, either having the vaccine done in urgent care or in our dental clinics, having a warm handoff to primary care that same day as they get out of the dental chair, let's walk you down the hall and get you your second dose of HPV before you leave. And so I think that's been a really cool thing, and we're working on it. This is a pilot that hopefully we will be starting in 2020 with the dental clinics. Urgent care started last fall, but just one more opportunity for us to kind of go above and beyond and think about other ways to do things. And I think that is it for me, and so I'll hand it back to Jen to finish up.
Dr. Singh, one question that came in that we'd love your input on. This particular individual said they get a lot of clinician buy-in, but they come up against the fact that HPV is not a required for school vaccine, and that many kids feel like they're getting 4 vaccines at one visit. Can you talk about how you address that and overcome that?
Absolutely. I think part of it is just, there's a couple different ways. One is having the conversation with parents early on about the fact that HPV vaccine is a really important vaccine. I think even the statement that I often will make with families about, we actually have something that can prevent a type of cancer is a big deal. And, lots of things are not required by school, but they're the right things to do for our kids. And so setting the stage early with parents, I think, is really helpful. And the idea of 4 vaccines, a lot of kids actually in that age group do better getting them all at one time versus the anxiety that's associated with delaying them even longer. So I think there are a lot of wins there. But I think really setting patients up for success and kind of knowing that this is coming in the future has been really helpful.
Thank you so much for that.
Yeah.
So just before we come back to the questions, we just want to take a few more minutes to make sure that the organizations that are on the call that haven't yet had the opportunity to sign up for We're In 2020 know how to do so. So Nikki, if you can help me make sure that I can access the slides. There we go. So if your organization has not yet signed up for We're In, this is the place to go, hpvroundtable.org/we're-in2020. And I want to clarify, we've gotten some questions from systems about data requirements. And basically what we've asked is that your organization is essentially making a commitment to prioritize HPV vaccination. And we just want you to share high-level data of what you found out about your baselines and your progress over the 12-month period. We're not looking to monitor data. We're not asking for you to share any kind of reports. It's really self-declaration. So please know, and we added more details on that on this page for you. We also, if I can get this to go forward, there we go. We added some new resources for leadership engagement. So we want to make it as simple as possible for you to secure buy-in from your senior leadership. And so on the far right, you see that there's a letter from the U.S. Assistant Secretary of Health, who launched the We're In initiative last month on our webinar, and he's provided a letter of invitation to healthcare leaders. The Roundtable has also written a letter for healthcare leaders to tell exactly how do you get involved and what are the steps. And lastly, we made an infographic for those visual learners amongst us on how to do so. We also want you to know, Marcy referred to the many resources that we've created to support this work, and you can find those in a curated webpage, hpvroundtable.org/health-systems. You see here we have a case study. We've done several case studies, organizations similar to Park Nicollet that have been doing HPV vaccination. So these are like great cheat sheets to learn what other organizations have done, what has worked, what can be improved. There's also all the clinician action guides, as well as supporting staff training tools around those. The video recordings will be there, slides, as well as a new series of interviews with national thought leaders that you can access around HPV prioritization. So, Sarah, I'm going to ask you to help. Is there any other, I think there's only one other question I see here about dental and having dental offices provide the administration if they're not connected to a facility. So we know that in many cases, and it's administration of the vaccine varies from state to state. So health systems which have dental underneath the same healthcare system umbrella, there can be much more coordination. We also have an action guide specifically for dental health professionals because there is such a strong connection between mouth and throat cancers and HPV cancer and HPV. And so we highly encourage everyone who might have an affiliation with the dental system to check out that guide, since that can be a great resource. Are there any other, let's see, we answered several questions about standing orders. So if you haven't seen those, there's a lot of links that we added in the resource box. And maybe one other question I'd ask both Marcy and Dr. Singh is, how do you get a parent on board, and what do you say if they're on the fence? Dr. Singh, do you have any particular lines that you like to use? You may need to unmute yourself.
Own children, and so this is something that I have recommended for my own kids. So I think that's really important. You have
Dr.
to.
Singh?
Yes.
I'm sorry, could you repeat that? You were muted, so we missed the first part of what you said.
Sorry, I was saying that I think cancer prevention is a big one, and making sure that parents recognize that this is one of the only vaccines that we have. I think also pointing out that we know that there is some data that shows that the earlier we give the vaccine, the more effective it is. The 2 doses versus 3 doses is a really big deal and a motivator for some of these younger kids that are nervous, and meeting parents where they're at. So making sure that parents, they don't feel forced into it, that it is their own decision, but at the same time, they are equipped with all the data they need to make that right decision for their kids.
Fabulous. Thank you so much. So as follow-up to this call, we will be sending out a follow-up email. We will send you links to the different resources. We will work on updating the frequently asked questions, as well as a link to the recording and the call slides. Those will be posted in our resource library. We've also put the links on here again for We're In and Health Systems. So with that, we're at 3 o'clock. We want to thank you for sharing time on your Friday with us. And a hearty thank you to Dr. Singh and Dr. Fisher-Bourne for sharing your expertise with us. Have a great Friday and weekend, everyone.